Our next speaker is Dr. Shalini Mohan, who heads the Cataract and Glaucoma Services at GSVM Medical College, Kanpur, and she is going to enthrall us with her pearl of wisdom. On to you, Dr. Shalini.
Thank you so much, ma'am. Thank you, ARC, for giving me the opportunity. I will be... Is my screen visible?
No. Yes.
Okay. So this is the case of a patient who underwent glaucoma valve surgery, later on developed cataract. So I'm going to show this video presentation of cataract surgery being performed in a patient of post-glaucoma valve. Now, we do understand that after glaucoma valve surgery, there are certain subsets of patients who develop cataract. And because of continuous endothelial cell loss noted in these patients, it is a challenge. Now, this is a patient who underwent, he had a neovascular glaucoma, and there was a cataract which formed 9 months after surgery. The intraocular pressure was well controlled. So we did a specular count, which is very, very important. We also did ASOCT to check for any tube corneal touch in this particular patient. Now it is important to make block, you can give whatever you want. The side port should be away from the bleb area and from the tube area. So staining is important because it improves the visualization. And then whenever you are manipulating, avoid any touch of the tube while insertion. Now this is a regular capsulotomy. While you are working under the tube, many times you will find there is fibrosis and you try and pull and it doesn't come out. So using Utrata's forceps is beneficial in such a scenario, and then you can complete your rhexis. Good hydrodissection with delineation is important, but again, you need to be very, very careful that you don't push the tube up towards the cornea so that you don't have any endothelial cell loss while doing this. Now, while doing phacoemulsification, it is important to check that you don't touch the tube or you don't push the tube. This is a long chopper I used because it was a hard cataract and direct chop I was doing. Now, it is important to make sure that minimal amount of phaco energy is being used and you do in-back phacoemulsification to avoid any endothelial cell decompensation. Now, the studies, they have also shown that the direction of the tube and the angulation of tube is also important. And in fact, this has been negatively correlated with the endothelial cell loss. So now, gradually the pieces were coming up and there was no actually epinuclear plate which can protect the PC. So I had to change the long chopper to a smaller one in between just to make sure that I don't puncture the PC. And following this, it is important to, now this is the change of the chopper and the last piece being taken up. You need to reduce your phacoparameters at this juncture. You can see that there is no epinuclear plate or no cortical matter. It was totally mature cataract. And viscodispersive OVDs can be used to protect the endothelial cells. Now, this was a piece which was hiding in the crevices and I used an iris repositor to take it up. Now, the foldable IOL in bag was transplanted. Having a well-dilated pupil is very, very important. If you don't, you can use the pupil expanders or an iris hook. In fact, people have started using iris hook to occlude the tube so that the inflammatory cells don't go inside the tube and they don't cause inflammation in the AGV. So now finally, this is the hydration of the port, and it is important to monitor the intraocular pressure in post-operative period because many a times there is rise in immediate post-operative period. Now to summarize, I would say that proper pupillary dilatation along with proper planned surgery is important with minimal tube manipulations. Avoid any corneal touch by the tube to the endothelium to protect the endothelial cells. Thank you so much for your kind attention.
Wonderful video, Dr. Shalini. I would want
Thank you, ma'am.
Dr. Shushmita to answer, or Shalini herself. How would you deal with a post-op IUP spike? Because this some of the fibroproliferative material or any debris could reflux into the tube. So
Definitely, ma'am. And in fact, there are several of the case reports also saying the similar thing, that despite whatever you do, you nicely wash it anterior chamber and you take your bimanual ports towards the tube so that you can take off all the debris. Still, some amount of debris and inflammatory cells, they do reflux through the tube area. And therefore, in immediate post-operative period, proper monitoring of IUP is very important. And the studies say that almost 1/3 to 1/2 of the patients, they do have rise in intraocular pressure in post-operative period. And therefore, at that juncture, we can add one anti-glaucoma medication whenever required. And then later on, but then as the inflammation resolves, most of the time, the anti-glaucoma medication can be withdrawn also. And later on, the patient's intraocular pressure gets well controlled, and then we can withdraw the medication also.
okay. Dr. Shushmita, would you like to add before we go on to our next speaker?
Not really, Dr. Chitra. Very well defined and well described. Thank you.
Yeah.
Thank you.
Thank you, Dr. Shalini.